Erika Stallings, and on behalf of the Vassar Center for BRCA, Black and BRCA Initiative, I'm here today with Dr. Payal Shah, one of the researchers and doctors at the Vassar Center, to discuss racial health disparities as it relates to breast cancer and hereditary cancer syndromes. Dr. Shah is an assistant professor of medicine in the Division of Hematology Oncology at the University of Pennsylvania, who specializes in breast cancer, ovarian cancer, and cancer genetics. With the support of the Vassar Center for BRCA, her research has focused on novel therapeutics, including targeted therapy and immunotherapy for patients with breast and ovarian cancer. So thank you so much, Dr. Shah, for being with us today. I know you're very busy, but I think particularly given everything going on with the pandemic, and then everything we've seen over the past few months in America, I think a lot of people are really beginning to think about racial disparities as they relate to health, and specifically cancer. And so to get started, could you sort of break down what we mean when we say racial disparities in cancer?
Yeah, absolutely. And Erica, thank you so much for having me and for doing this session. I agree with you. It's incredibly important to talk about these topics, especially now. So it's a pleasure to be here. So when we talk about racial disparities in cancer, we're talking about differences in oncologic care that occur along a patient's cancer journey at every step of the way. So we're talking about how likely patients are to get their age-appropriate or recommended cancer screenings, how likely they are to bring a symptom or a concern to medical attention, and how likely they are to get a timely evaluation of those symptoms or concerns after they're recognized. We're talking about differences in treatment. We're talking about differences in patient and provider communication. And some of the considerations that I just mentioned do relate to biases, but there are also systemic factors as well. So how, and here we see an intertwine of not just race, but socioeconomic factors and even geographic factors. So how likely is a patient to be able to take time off of work to attend a visit, or does a patient have health insurance? Are there providers in the area that a patient can actually access? So there are a lot of different factors in play, and that's really what those are the issues that we think about when we think about racial disparities in cancer.
Got it. And we'll come back to talking about some of the things you touched on in terms of what drives those trends. But before we get into that, I guess currently in the United States, what's some of the data that we see as it relates to incidence of breast cancer and the mortality rates for different racial backgrounds?
Yeah, so that's a great question, and it's actually pretty remarkable. So some of the best data that we have comes from the American Cancer Society, and they look at incidence, mortality, survival, and screening. And in their most recent update in 2019, they actually noted that the overall incidence of breast cancer is rising ever so slightly by about 0.3%. But the breast cancer death rate has declined significantly overall. And there was a decline in the breast cancer death rate across races. So for Hispanics, Blacks, Whites, Asians, really across races. So that part is good news, and I think it does speak to the fact that screening and treatments are getting so much better. But when we look at the difference in cancer mortality between Blacks and Whites, there is an astounding and concerning gap. So the death rate is 40% higher in Blacks, despite a lower incidence of breast cancer, than it is in Whites. And this gap has been long-standing, so this gap has been present basically since the 1980s and persisted for about 3 decades, and only in around 2011 have we seen the gap stabilize. It was actually widening before that. So, but obviously it's stabilized at an unacceptably high number. So the disparity is really evident in Black women who are under the age of 50, where the death rate is basically double that of the death rate of patients who are white but have breast cancer.
Wow. And that's something I wanted to really touch on when you talked about the fact that you really see that high death rate in Black women under the age of 50. So my own personal experience with breast cancer is that my mother is a 2-time breast cancer survivor. She was diagnosed for the first time at the age of 28, and then she was diagnosed again in 2007 when she was in her mid-40s. And that's when we eventually, she underwent genetic testing and learned that she had a BRCA2 mutation. And so one of the questions I wanted to ask you is, do researchers know why that sort of the connection between sort of like age and breast cancer in Black women? Because I think before my own personal experience, I really thought breast cancer was something that happened to older women.
Yeah, that's a great question. And I think some of what you might be getting at is that there seem to be some real biological differences between breast cancer in Black women and breast cancer in white women. And I want to be clear that breast cancer does happen in men as well. It's just that the majority of patients that we see are women. So certainly breast cancer does affect Black women at younger ages, typically, than it affects white women. The difference there is about 2 years. Black women are also more likely to have hormone receptor negative disease, particularly triple negative disease, and those are kind of, that's a more aggressive subtype of breast cancer, whereas white women are less likely to have triple negative disease if they have breast cancer. And so, other trends that we see that are concerning are that Black women with breast cancer are more likely to be diagnosed with larger tumors that are higher grade and later stage, and all of this is part of what contributes, but not the whole picture of what contributes to a higher mortality for Black women with breast cancer.
Yeah. And how does family history, I guess two questions for you. How does family history tie into this? And then how does screening tie into it? Because, a lot of times when I have conversations with my girlfriends, people are like, well, I don't need to start mammograms until I'm 40. And then some people even say I don't need to start mammograms until I'm 50. But how might that be different, based on family history or other factors?
Yeah, so family history is incredibly important, and alongside that, it's important that the person who is making recommendations, the provider who's making recommendations to you about when you should start screening, actually knows about your family history, and that means they have to actually ask about it, and they have to ask the right questions. So some of the questions that we want to know about are, is there a family history of cancer? What types of cancers? At what ages were people diagnosed? Which cancers happened on mom's side of the family? What happened on dad's side of the family? What is your ethnic background? We do see ethnic background coming into play as well. And so I think the other aspect of family history that's really important for physicians or providers to ask about is how big is your family? So if there's not a lot of if there aren't a lot of family members around, then we don't have the data that we need to have a really informative picture of what someone's family history looks like. But certainly having a lot of cancer diagnoses in a family, or having people who are diagnosed at younger ages, having cancer diagnoses that kind of fit in with a specific genetic syndrome, or having what we call vertical transmission, meaning father to child or mother to child transmission of cancer. Those are all things that kind of clue us off to there being a potential inherited component to cancer risk. And so I think it is important for that information to be shared with the provider who's telling you when you should be getting your mammograms or other cancer screening, and whether or not you should have genetic testing. And I think one area for improvement is for people to talk about that more. That means providers asking about it more, and patients feeling comfortable sharing that information with their providers.
Yeah. And so you just said something really interesting. You talked about if you have this family history, it might be a telltale that there's something hereditary going on. And for anyone who's listening who might not be familiar with hereditary cancer, I guess could you just break that down a little bit?
So when we think about hereditary cancer, we're really thinking about cancer risk that's passed on from one generation to the next within the same family. So we know that there are certain syndromes or genes that are associated with a specific with a specific constellation of cancer types. So for example, one of the most common sources of hereditary breast cancer is an inherited mutation in a BRCA gene, whether it's BRCA1 or BRCA2. And if an individual has an inherited mutation in one of these genes, then that individual is at a higher risk of developing breast cancer, if they're female, ovarian cancer, pancreas cancer, and other cancers. So what we mean by hereditary cancer is cancer that one can actually, cancer that the risk is passed on from generation to next.
And is there any available data about how common these hereditary, like let's take BRCA, for example. Is there any data about how common BRCA mutations might be in the Black community or amongst Black populations?
So there have been various estimates, and it depends on which population of patients that we're talking about. If we're talking about Black patients overall, so whether or not they have a diagnosis of breast cancer and whether or not they have a family history, that number is actually hard to pin down because historically we have not been doing universal screening of Black women who don't have, or of any women who don't have a family history or don't have a cancer diagnosis themselves. But we do know that in people who have breast cancer, especially women or men who have earlier diagnoses of breast cancer, the estimates of a BRCA mutation in the Black community has been noted to be anywhere between 11 to 20%, and that just depends on, again, which population we're talking about.
Got it. And so, you know, it's interesting because I underwent genetic testing, counseling and testing 6 years ago, and learned that I carried a BRCA2 mutation. And I think one thing that was really interesting for me is that I just didn't really see a lot of other stories from Black women like myself, which is how I started working with the Vassar Center. And so my question for you is, you know, earlier in our conversation, we were talking about these disparities, and you were saying the disparities sort of touch all parts of the treatment and the access. And is there any data about disparities as it relates to Black women and men, access to genetic counseling and testing, referrals, things like that?
Absolutely. So there have been a few major studies over the last couple of decades looking at disparities when it comes to genetic counseling and genetic testing. And one study actually very clearly showed that there are differences in the recommendations that women receive if they're African American as compared with if they're not. So Black women are less likely to receive a recommendation to undergo genetic testing than white women. There was another study that was a little bit older that actually was based out of Philadelphia that looked at about 400 women, African American and white, and these women actually have family histories of breast cancer. And this study found that African American with a family history of breast or ovarian cancer were significantly less likely to undergo genetic counseling and testing than white women who also had a family history. And that's pretty disturbing. And actually, the white women were almost 5 times as likely to undergo genetic counseling for BRCA1 and 2 mutations than African American women. And that was seen even after the study corrected for things like how strong was the family history, so how likely was a patient to have a BRCA mutation. That study even corrected for socioeconomic characteristics and risk perception and worry from the patient's attitudes about risks and benefits of testing. So I think that definitely there is some element of how often are women getting recommended to undergo genetic testing, and then there seem to be other factors at play as well.
Oh, got it. And this may seem obvious, but when you see these types of disparities in something like access to genetic counseling and testing, like what are the sort of ripple effects of that as it relates to some of those larger mortality and incidence rates that we were talking about?
I mean, it's just so incredibly important. Obviously, one of the main reasons that we want to identify anybody who has an inherited breast cancer syndrome is because goal number 1 is to prevent cancers from ever happening. And if we can't identify the patients who are at risk of developing cancers, then we're not able to advise them to undergo the right risk-reducing measures. And that's That's a really fundamental problem, and I do think that that contributes to that 40% excess mortality that Black women with breast cancer have as compared with white women. I think, some of the things that we do, for example, if we find a BRCA1 or 2 mutation, is we talk to women about doing screening beyond what we do for women who are at average risk. That includes breast MRIs in addition to mammograms, and we talk about medications to reduce cancer risk. We talk about having surgical removal of the breast as a preventive measure. And we talk about doing the same thing with ovaries and fallopian tubes to help prevent ovarian cancer. And really, preventing cancers are one of the fundamental goals. And when we're not able to do that because we haven't recognized that there is an inherited predisposition to cancer there, then that's really a failure on our part.
Yeah. And no, I think about all the time, as I sort of mentioned earlier, my mom had breast cancer twice. And, if we had known that she had a BRCA mutation before her second occurrence, to your point, she might have been able to, undergo some preventative measures or do enhanced surveillance. And so I think about it all the time, and I feel very fortunate, because of what she knew, I was, able to take some of those preventative steps. And so I think that I often think about is, okay, I'm sort of the beneficiary of this really great health information. And how do you get that to other people? And I think a lot of people watching this are also, advocates or people who really care about this topic. And so what are things that providers can do, that patient advocates can do to sort of help to tackle this very large and important problem?
Yeah, I think it's a great question. I think that we all recognize the need to do better, and I do think that there has been, just like you were saying initially, with the increasing recognition of events ongoing in the country, there's been an increasing recognition that racial disparities really permeate broadly. And so, Penn, and I know other institutions as well, have started forming task forces to discuss systemic bias, unconscious biases and systemic racism, to see how we can actually dismantle things that we may not even recognize as being there. Penn and other places have actually had providers attend and participate in trainings where we're kind of forced to think about things that might feel uncomfortable but are really important to acknowledge so that we can do our jobs better. I think that, you spoke about the role of patient advocates. It's funny, I actually was part of a grant that was submitted recently, and some of the feedback that we got was, please include a plan for increasing recruitment of Black patients and consider having a Black patient advocate on board. And I think that having visible representation that goes into all the different populations that are not participating as much is really important. And our plan there was to, there are organizations, as I know of individuals who have hereditary cancer syndromes who are Black, or breast cancer who are Black, and it's kind of our job. One of the goals that we have is to partner with those organizations more so that we can all kind of spread the word that these things exist. And please, we want your participation. We want your feedback on our clinical trials. We want your help with patient recruitment. So I think that some of the things that we can do are really just partner more with the community and raise awareness that this is an issue, and do what we can to kind of dismantle it at every level, at the individual level, at the systemic level, really at every level.
Yeah. And before, and I want to come back to that in a second, but, for you, Dr. Shah, I remember when I met you, I know that you have actually done a lot of research and grants as it relates to disparities in breast cancer. And so I guess, to be personal for a second, why is that research important to you and something that you've chosen to focus on?
Well, thanks for asking that. I think racial disparities definitely has been something that I, as a brown woman, have been familiar with personally kind of all my life. It's important to raise recognition that this actually does exist. The most distressing things to me is when I see it actually impact patient care. So, for example, when you see this mortality gap in breast cancer in Black women with breast cancer compared to white women, I mean, that's just astounding to me. That's astonishing. That's horrifying. And I think one of the other aspects of this is that what we do see is that patient trust and mistrust of the medical system is really important and it's really impactful. I know that my own family members definitely, I have family members who are maybe of older generations who definitely trust a doctor more if they're also Indian. And so I think it's important to raise awareness of things like this because having representation that looks like you, going to a doctor or seeing doctors out in the community that look like you, seeing genetic counselors out in the community that look like you, I think that these are important things for us to recognize the need for.
Yeah, definitely. I mean, it doesn't relate to our topic today, but there was a very interesting study that came out, I want to say 2 weeks ago, about how when Black women see Black OBGYNs, you see a drop in the maternal mortality rates. Well, Dr. Shah, I just want to say thank you, because like I think, I do see on a lot of these online conversations, I think there are a lot of patient advocates who are sort of starting to wake up to this topic and want to know what they can do. And so I think everything you touched on, both from like an educational perspective and sort of a roadmap going forward, is really great. I also wanted to let our listeners know that if you are interested in these topics and work that you can maybe do to help reduce some of these disparities, the Vassar Center, as I mentioned at the beginning of the call, is launching a new awareness campaign, Black in BRCA. It will be targeted information, videos, posters aimed at increasing awareness